We move ahead with the second short case, will be presented by Dr. Shiva Chahal. Shiva, you can start your case. Yeah.
Chalo.
My patient is a 40.
Mike, where is your box, that thing?
My patient is a 44-year-old female, 44-year-old female, a school principal by profession, right-hand dominant female, with a diagnosis of right side distal and radius chronic osteoarthritis of 3 months duration. Currently disabled with activities of daily living, with the painful stiffness of the wrist and fingers. Currently disabled with activities of daily living like eating food with the hand or buttoning, unbuttoning shirt or doing her household chores. So I would like to proceed with the history, sir. Then, sir, on history, patient was apparently asymptomatic 2.5 months ago when she had a cat bite injury to the distal forearm, after which patient has developed pain and swelling in the right forearm and wrist. And after which patient has shown to a local doctor who had given some medication and done the dressing for the cat bite wound. But the patient's pain did not subside, and patient was having a pain which was sudden in onset and continuous in nature, and also a throbbing type of pain, which was more present during the night time. And
Fever. She had fever.
Sir, but patient has no history, has given no history of
With
fever.
that swelling, did she have fever?
No, sir. At that point of time, also patient did not have any significant fever. Then after that, the cat bite wound healed with the dressing, but after 10 days of the cat bite, patient has developed multiple blebs over the backside of the distal forearm, and after those blebs have burst.
Please
and,
don't say backside. Hello.
Dorsum. Okay. Or the dorsum of distal forearm. Patient has developed multiple blebs over the dorsal of the distal forearm, which have burst to give rise to the purulent discharge, which was copious in nature and foul smelling. Then for that, family doctor who had again advised the cleaning and dressing of the wound and some medication, but the discharge did not subside and it increased. Then there is also a history of reduced movements at the wrist and the fingers, which is progressive in nature since the past 2 months. And for the last 10 to 15 days, patient is unable to do her activities of daily living like eating food with the hand or able to dress or undress herself with that hand or doing the household chores. Then patient is a known case of type 1 diabetes mellitus on insulin.
Before that, management history, any management
Ma'am, she had only shown to her local physician who had advised medication and cleaning and dressing of the wounds. No specific treatment has been taken by the patient.
And diabetes.
And there is a history of type 1 diabetes insulin, and which is probably uncontrolled because patient has gone into diabetic coma 3 times in the past.
Oh.
Yes, then, sir, I would like to proceed with the examination. And then, sir, on inspection, on general examination, there is no stigmata of tuberculosis. The general examination is non-contributory. Then, in the local examination on inspection, there is the attitude patient keeps the arm adducted.
One suggestion to all of you: please don't use this word inspection palpation. Keep in your mind. Just start. These are the inspector findings. These are palpatory findings. Because it not looks good.
Then, sir, a patient keeps the arm by the side of the arm adducted by the side of the body, the elbow in flexion with the forearm.
No, first, you have to tell only the deformity portion, then tell attitude or whatever the things.
Sir, actually, the patient is not having any fixed deformity, and she keeps the forearm in pronation.
What is deformity? What is attitude?
The attitude is the most relaxed position of the limb which the patient adopts to ease the pain. Deformity is a disfiguration or a mishappening.
So deformity is that when you palpate. When you inspection, it is a attitude. Like the hip is in attitude of flexion, external rotation. We don't know what is the flexion deformity until you do the Thomas's test.
Yes.
So what is the attitude of the shoulder, elbow, wrist?
Yes.
Tell me.
Sir, currently the shoulder is adducted with the arm by the side, and elbow is flexed with the forearm in pronation, with the wrist in slight palmar flexion and ulnar deviation, and with the fingers extended and the thumb abducted.
Right. Now, what are the local findings on inspection.
Then, sir, there is a presence of three sinuses on the dorsal aspect of the distal radius, which currently having scab at their openings, right of scab at their openings, and there is associated increased pigmentation of the skin around the sinuses. Then,
Right.
sir, there is also two healed hyperpigmented pinpoint scars on the lateral aspect of the distal end of radius, which is suggestive of the which is healed by secondary intention and suggestive of the injury to the which is cat bite injury to the distal forearm. Then,
Right.
sir, there is also obvious there is wasting of the mobile wad of Henry and also the thenar and hypothenar muscles.
Mobile ward of Henry. What are the muscles of mobile ward of Henry?
Extensor carpi radialis longus, extensor carpi radialis brevis, and the brachioradialis.
Very good.
Then there is wasting of the thenar hypothenar muscles and the first dorsal web space. That is being appreciated.
Show the hand. Can she supine it and show the wasting?
So she can with the shoulder she can do.
Okay, show.
Yes.
ऐसे करो. Okay, so hypothenar and thenar wasting. Okay, fine. Proceed.
Then, sir, on further examination, sir, there is tenderness, there is local.
Now palpation. On palpation,
Okay, sir.
you say that inspection, palpation, percussion, auscultation has been there ever since you're in
Yes, sir.
MBBS, right?
On
Palpation.
there is local rise of temperature present on the distal aspect, distal aspect of distal end of radius, dorsal aspect of distal end of radius. Then there is local tenderness is present. Then, sir, the sinuses are fixed to the underlying bone and they are immobile, and with also the tenderness present on deep palpation of the sinus. Then, sir, Then, sir, I would like to proceed for the movements examination. And there is no discharge which is as such apparent on pressing the sinus
Okay.
currently. Then, sir,
Okay, movements.
movements, there is painful restriction of movement, gross painful restriction of global restriction of movements at the wrist and at the interphalangeal joints and the metacarpophalangeal joints with flexion of with the patient having kept the limb in around 10 degree of flexion with further flexion up to 20 to 30 degree and extension she can bring her arm to the neutral.
Flexion means palmar flexion, dorsiflexion, you say, no?
Okay.
Ah.
So palmar flexion possible up to 20 to 30 degree with the dorsiflexion of only 10 degrees possible. Then, sir, the ulnar deviation patient can do up to 20 degrees with no active radial deviation being possible.
When sure.
So you are talking about the wrist. So how will you test?
Ideally, we should test with the arm directed by the side and
No, that is for supination, but dorsiflexion, palmar flexion, adduction, abduction, how will you test for the wrist?
for this we should make the fist and then we should ask the patient.
Where will you hold?
So I will have to stabilize the
Radius.
Yes, sir. So
Stabilize the radius
she's
and then
not able to make the wrist, so I have tested. She's not able to make the wrist with the fist with the hand, so I have just tested with the.
so how?
extension.
So you're holding the distal radius. Now what else? What is the next thing that you have to hold?
So
Wrist now. What is wrist consisting of?
wrist radiocarpal
Radiocarpal means which joint, which carpal bones?
scaphoid and lunate.
Then, so hold that.
Yes, sir.
Will you first do active or passive?
First active.
Active,
First
social active.
Why?
Because first we should see how much the patient is moving, then further.
Yes, please don't do passive first.
Active first, correct.
And इसको ऊपर लेना है.
You are paining the patient, you will straight away fail. Look at the patient's face.
Okay. So, sir, this much only.
Dorsiflexion, plantar,
इसको
palmar. So where are the movements occurring?
Sir, at the.
Ma'am said it is that you have to do active. So is it the true movement that is acting at the wrist or something else is also could be happening at the foot?
Palmar joint, there can be a.
Mid palmar joint. What is mid palmar? There's a mid tarsal joint. You have created mid palmar joint over.
What is your diagnosis in this?
No, wait, one sec. She is doing this also, right? Is she doing movements of the wrist or something else? How much is the intercarpal flexion and dorsiflexion and palmar flexion and the radiocarpal?
Sir, radiocarpal normal palmar flexion is up to 70 to 80 degree, and dorsiflexion is
But
also
how much is that part? Suppose the patient is doing without touching, suppose I am doing this, what is happening at the wrist? How much is the intercarpal and how much is the distal radius carpal?
around 50%.
50-50. So therefore it is possible that the patient could be having it totally stiff as it happened in that foot case. You remember you were there for the foot case on
Yes.
Friday?
Yes.
The patient was doing this, but when you stabilize the ankle joint, there was hardly any movement. So stabilize now. What ma'am says is correct. What is the passive? What is active? Active she is doing. So very good. Active. So therefore the wrist is not involved, you'll say. But now you stabilize the distal radius and the proximal carpus. That means the scaphoid and the lunate and the triqueter. Triqueter mainly goes to the head of ulna and the TFCC. You do it, no?
Okay.
What ma'am said, don't give pain.
That's all.
How much you have?
Only about 10 to 15 degrees.
Of dorsiflexion at the radiocarpal joint. Palmar flexion,
दर्द तो बताना आगे.
she has. She has some.
Yes.
Abduction, adduction.
Sir, so ulnar deviation, active ulnar deviation only 20 degrees possible. दर्द हो रहा है. That's it.
Okay. Now intercarpal, you can't immobilize the distal and the proximal carpal. You can't. How can you hold the two carpals? So that is not possible. But you stabilize the distal radius and see what is happening in the intercarpal. I mean the radiocarpal joints. So how much the movements?
Sir, 10 degree of dorsiflexion and 20 degree of palmar flexion and for 20 degree of radial deviation. So 20 degree of ulnar deviation with restricted radial deviation.
Okay. So it is restricted. Is it ankylosed?
No, sir.
That is a movement. Okay. Now pronation, supination. How will you see?
For pronation, supination with the arms by the side of the patient. Yes, sir. Ideally, we make a fist and give the pen to hold for the patient, and so we can see, but she is unable to make the fist.
Okay.
अभी हाथ अपना, so I will hold in moment and हाथ को आप ऐसे बाहर भी कर लेना. नहीं ऐसा like this. Yes. करो. That's all she will do.
So supination she has quite good.
Yes.
Pronation she has.
Pronation is restricted. Rotate.
She has, no?
Yes.
So pronation, supination is not restricted.
Yes.
Dorsiflexion, palmar is restricted but not ankylosed.
Yes.
Right? So what is your conclusion from this?
Sir, this can be due to.
What about the hand? How much MCP movement
hand.
does she have?
For the MCP, ideally we should supinate and then check.
So check. She's got supination.
थोड़ा बाहर की. पेन हो तो बता. अभी ये इसको
ये बंद करो. फिस्ट करो, फिस्ट.
फिस्ट बनाओ और कितना होगा तो.
Okay.
Is the MP-IP joint affected?
No, sir.
No? Can she do that? But she's not able to do the
Yes,
fist.
there
So
is
how
a-
are you saying it's not
There is a
affected?
stiffness, but there is full extension is possible with restriction of flexion.
Flexion.
Yes.
Right. What is the normal position of the hand for immobilization in a cast or
So,
something?
we use the intrinsic position with the wrist in 20 to 30 degree of dorsiflexion
Mm.
with a slight ulnar deviation and 45 degree of flexion at the metacarpophalangeal joint and the IP joint in extension or just 10 degree of flexion.
IP should be straight and MP should be at 90. So you will stretch all the capsules and they'll not get a contracture. So this is how it is. If you give any hand this position, normally they'll not get a FFD of the fingers and they'll not get a claw hand of the MP joint. So this way, that is the answer. 90, 180. End of it. So what was I asking? What is your conclusion now?
Sir,
Supination, pronation she has.
yes, sir. And some amount of dorsiflexion, palmar flexion also patient is having. Also, the metacarpophalangeal and IP interphalangeal joints appear to be stiff, but they don't seem to be affected by the disease process as of yet.
Okay, what else? What else you have forgotten to palpate?
Sir, palpation of the bony landmarks around the wrist. That will be the radial styloid, the ulnar styloid, the Lister's tubercle, and medial epicondyle and the lateral epicondyle also.
So their relation is maintained?
3-point relationship is maintained.
No, no,
And
not
on
3 point.
yes,
For the distal
also, yes,
radius
sir.
and the
Yes,
head of
distal
ulna.
radius- The distal radial styloid is about half an inch distal to the ulnar styloid, Professor.
Lymph nodes.
Yes.
Lymph nodes,
There is no epitrochlear lymph node palpable in the patient.
Axillary.
axillary.
Also there.
That's an
Okay.
important part.
Yes.
You should be aware. So what is your diagnosis,
So what is
doctor?
the diagnosis?
So
Yes.
my diagnosis is a 44-year-old female, principal by occupation, right hand dominant, currently suffering from right distal and radius osteomyelitis with painful stiffness of the wrist and fingers, with currently disabled with activity of daily living like buttoning, unbuttoning shirt or eating food with hand and doing.
Tell me, is it acute? You said osteomyelitis. Is it
is,
chronic?
It
Is
is
it acute?
It appears to be an acute on chronic type of osteomyelitis.
Cat
So
bite.
what are the features of chronic osteomyelitis you found on that patient, on this patient?
Sir, there are sinuses with healed scabs present on the dorsum of the wrist and hyperpigmentation of the
So
skin.
that would indicate a chronic osteomyelitis, healed sinuses.
So presence of sinuses is indicative, though.
What are the
Chronic
features of chronic osteomyelitis to say that the patient has chronic osteomyelitis? Tell
Sir,
me, what are the features?
Features of chronic osteomyelitis include
in a patient.
persisting sinuses with on and off discharge or
First is
discharge
history timeline. History,
Sir,
time.
2 months duration. There is more than 6 weeks of 2 months duration. Then
So you said sinuses healed or discharging. One. You must go 1, 2,
Yeah,
3, 4.
4, 5.
Like that
You have to
go
tell
that
why it is
Govalia
a
book
chronic
was there. Na? Is it still there? I don't know in medical. Do that way now.
sir, the duration. First is the duration, that is 2 months. Then there is a persistence of sinuses since the past 2 months.
Third.
With on and off history of discharge. Then patients sometimes also give history of discharge of bony spicules. Then or if there is any chronic non-healing ulcer with implant exposed.
In this case,
that sinus has to be adherent to the bone.
Yes,
That is
sir.
very important.
Yes, sir.
Otherwise, it's not chronic osteomyelitis. It can be ulcer
Yes, sir.
also.
which you said.
Yes, it's adherent to
Third.
It's adherent to the bone.
Yes.
Irregular. Is there a thickening irregularity
There is
of
a
the
thickening
bone?
of the distal and radius.
Is there any bony spicules? Is there any red sprouting granulation tissue coming?
That is not.
And bone
So these are
thickening.
these are the signs of chronic osteomyelitis you got to look.
And
Thickening
discoloration.
irregular bone.
Skin discoloration. You said all that, I think. Okay, so what is your diagnosis? I want to know from clinical examination, is the carpus involved or carpus is not involved?
Sir, there appears to be a minimal inflammation.
And distal radial ulnar joint involved or not involved?
Sir, there appears to be minimal inflammation of the intercarpal bones as evidenced by tenderness over the carpus and distal end of radius.
So it's possible,
Yes, sir.
but not total,
Yes, sir.
right?
Yes.
Because she has got some dorsiflexion, some palmaflexion, adduction, abduction, and distal radial ulnar joint.
Distal and radial joint, if we try to do the allotment, there is pain. So
Is it involved? Not involved?
But it is not completely involved or disturbed. The supination pronation is.
That's right. Because the ulna will dorsiflex and it will palmaflex when you're doing supination and pronation. If that is gone, then this will not happen.
What would you like to do for the patient?
Sir, I would like to do X-ray of the wrist, forearm, AP, and lateral.
Overexposed. Overexposed X-ray. This is so you'll have to contrast. Now see it from nearby.
Sir, this is the X-ray of the left forearm with wrist, AP, and lateral view of a skeletally mature skeleton, which is demonstrating, sir, there is a soft tissue enhancement over the radial aspect of the distal and radius.
Enhancement is not on X-ray.
Soft tissue.
Soft tissue swelling. Enhancement will come on MRI.
There is a soft tissue density on the radial aspect of distal and radius with minimal periosteal reaction being observed on the radial aspect of distal and radius.
And
then on the lateral view, sir, we can again observe the soft tissue swelling, and there is a minimal cortical destruction of the dorsal aspect of the distal and radius.
where the cat bite has occurred. Carpus.
Sir, there is appears to be a generalized osteopenia of the.
Is it
carpus.
involved? Is there any reduction in the intercarpal space?
No, sir.
See, his clinical was correct. Huh? She had dorsiflexion, she had palmaflexion, she had adduction, abduction, and the distal radius. So that is how you come to a clinical diagnosis. If that was involved, she would have been totally stiff. And lines of Gilila, are they involved?
They are maintained
What are Gilila lines?
with we have three gillulas lines.
Tell me.
First one is proximal for the proximal carpal row.
Hmm.
Then the second one is for the distal articular surface of the proximal
Proximal
carpal row.
carpus and
Third one is for the proximal aspect of the
distal carpus. Very good. So these are very important. If they are disturbed, means there could be a intercarpal infection, or in the cases of VCDC, you will find that that also is deranged, or in distal radial fractures, intra-articular. Very important is Gilila lines. You all know Gilila lines? That should be by heart, total. Yes. Next. What do you want to do?
Sir, I would also, since there is no evidence or gross evidence of chronic osteomyelitis as such, I would like to go for a MRI to.
MRI. See the MRI. MRI. This is good MRI. See the carpus is not involved. See that his clinical diagnosis is so good on examination. So where is the osteomyelitis? In the
distal radius.
Radius, and the intercarpal joint, the Gilila lines, and the distal radioulnar joint is normal. That is how you come. So supervisor telling something, this, that, you make mistakes then. Agreed?
Yes.
For the exam. So what do you find?
Sir, there is a increased. There is a T2 weighted image of.
So where is T1? T1 hai ka?
So this
T1
is
will show the articular structure of the bone. T2 will show inflammation. So now first you see the T1.
So this is a T1 weighted image of the wrist with the distal radius and ulna. So sir, here we can see some intensity changes in the distal end of radius, which is hypointense.
Yes, whereas the carpus is totally normal. The distal ulnar head is also totally normal. That is how your clinical diagnosis is matching with this. Understood, doctor? Now, yes, what do you find? Yes, now you find the T2.
So T2 weighted showing T2 weighted image of the wrist joint with the distal radius and ulna, showing increased marrow intensity in the showing marrow edema, which is evidenced by increased intensity in the distal end of radius.
Okay. Now, axial.
What is your? Yeah.
1 minute.
Yeah, sorry.
Axial, what is showing axial?
In axial, sir,
They have shown both T1 and T2. So
Yes,
that is good. Tell.
sir, there is altered intensity again in the distal and radius metaphysis. There is a cortical breach on the dorsal aspect, and probably there is a infection, collection, probably a abscess in the dorsal aspect. And also, we can appreciate a sinus going through the between the extensor tendons.
Right. So is there a tenosynovitis? Good. You're doing good, I think, doctor.
Tenosynovitis is a possibility in this case.
So there is possibility of an abscess collection, which we see in the right side view in the axial lower, also on the top, and we find that there is some tenosynovitis and affection of the distal radius. Correct? All right. So what do you want to do?
So first, I would like to go for hematological investigations.
What investigation?
ESR, CRP, total counts.
And
For what?
and
For what?
Sir,
What are you looking at?
First, obviously, this is an inflammatory condition, so there will be increase in the ESR, CRP, and total counts. But then we also need to get a baseline value of the patient for further.
Would you like to give a differential for this patient?
Sir, it is a osteoma. It can be. It is not actually based on now that we have seen the radiology. It can be probably a subacute type of osteomyelitis.
what differential you are asking for tuberculosis?
Any chronic, subacute or chronic? Can it be?
Indolent, yes, sir. Chronic granulomatous infection with a rumbling activity, like tuberculosis.
Okay, so what investigations then? CBC, ASR, CRP, and
That all. Then, sir, I would like to get my microbiological diagnosis.
how?
By either.
Now this is where you are doing well. Now you will not do well. You will take this thing, you will dip somewhere, you will set, and then you start antibiotics. That is not correct. As orthopedic surgeon, you have to go inside and find out what is the germ that is causing that. So forget that. You can't do that tip thing.
Sir, I have one doubt. Like,
We
can't do tapping of that abscess.
Is there a collection there? Abscess is there? Okay, that you may do. But investigation, what other things you have not said?
No.
1 minute. Let him answer that. Sugar. She 3 times she was in coma.
Yes.
What is her HbA1c? What is the status of the kidney? What is the creatinine?
Yes.
All that you have to check. And sugar, control that, and then go ahead. That is very important.
Now, the conclusion part of this session is management. Now, how would you
Sir,
go for management?
Since there is a collection on the roster
No,
as per-
plan is important part. Plan. What you will do?
Sir, after getting the microbiological diagnosis,
Everything's over. Now plan is now go for procedures.
See, are you going to operate or you're not going to operate?
That's I'm asking.
You are just going to do that and give antibiotics and let that the general practitioner, you're going to treat
there
her.
is a collection on the dorsum of the
Hmm.
wrist with the inflammation of the distal radius cancellous bone.
Hmm.
So I would like to go for debridement of
And there is sinusitis.
and tenosynovitis.
See, that's why I'm asking. What will be your surgical plan? One is debridement and then other things.
And then there is a curettage of the
Now you are mixing your debridement, curettage is separate part or debridement is separate? Huh? So that is one part is debridement.
yes.
And what is the other part?
Other parts, sir, if we have to put, we can also put the local antibiotics.
So you have to tell in the one line, yes, sir, I will go for the local antibiotics as well as systematic antibiotic will not affect, will not have a, take the care. So I will go for debridement and local antibiotic.
Yeah. And you will send it for culture sensitivity.
What
Yeah,
are
and
the
gene
local
expert, everything.
antibiotics you use?
Sir, we can use vancomycin, teicoplanin, gentamicin, tobramycin,
Okay.
impregnated with the bone cement that we have with calcium sulfate and phosphate.
Okay. Is it possible to use some local antibiotic in the radius? You are treating this radius. Is it advisable to use and how would you use local antibiotic?
So local antibiotic, actually we are mixing with the preformed
No,
cement.
I am asking, the question is that the radius is there.
Yes, sir.
How would you go for?
If the after debridement of the bone and the infected tissue in the bone, then there will be a gap, there will be a dead space created in the bone. Then we can pack that dead space with the antibiotic cemented beads.
Why cemented beads now? You'll have to remove the cemented beads. So something else is available, which, then right and left, Mohan Desai and all are using here.
Yes, sir. Calcium sulfate beads.
With proper antibiotics, with gram positive and gram negative, you can add what you want. You can add amic acid, you can add vancomycin, you can tobramycin, and put those beads there if there is a cavity. Why you are saying cement?
Yes, sir. I meant,
Forget that cement now. You are using the stimulant beads, no?
yes, sir.
Right and left. Then
I meant
where you
that.
got the cement idea?
No, sir, I meant that one.
You meant that. Okay. He meant that.
We are regularly using, still you are failing.
Yeah,
to-
then, that's what I'm asking.
Why
Khandelwal
you
sir.
need?
Every day and night you are
We are
using.
regularly using the
I
stimulants.
meant that.
Now you are failing and you still you are telling cemented beads. What nonsense you are telling?
So we'll